Good morning, Mahaba. My name is Su Hong, and I'm from the first affiliated hospital of Chongqing Medical University. Our study focuses on a promising therapy for adolescent major depressive disorder, high-intensity transcranial alternating current stimulation, or high TACS. Let's dive into what we've discovered. Let's start by understanding the problem we are facing. Major depressive disorder in adolescents isn't just feeling sad, it's a debilitating condition marked by persistent low mood, loss of interest, and significant functional impairment. Worse, adolescents with MDD face unique risks, higher suicide rates, academic struggles, and social isolation. Globally, MDD prevalence has surged from 24% in 2001 to 37% in 2020. Here in China, 14.8% of adolescents meet the criteria for MDD. Now, current treatment like SSRIs, while helpful, have serious limitations. They take weeks to work, have low response rates in teens, and carry a black box warning for increased suicidal thoughts early in treatment. Psychotherapy, though beneficial, is costly, time-consuming, and less effective in adolescents than adults. So we're stuck in a critical gap. How do we deliver fast and effective care to these vulnerable patients? That's where our research begins. Now you may ask, what about non-invasive brain stimulation, which we call the NIPS, like ECT or rTMS? Let's break this down. ECT, while effective, requires anesthesia, risks seizures, and is heavily stigmatized. TDCS is safer, but only reaches superficial brain regions, missing deeper emotional circuits. rTMS can reliably target structures like the amygdala and may worsen anxiety in teens. Existing methods either lack precision, depth, or safety. We need a better tool, one that combines efficacy with minimal risks. That's the promising of high TACS. This brings us to transcranial alternating current stimulation, TACS. Unlike its predecessors, TACS use adjusted intensity and tunable frequencies to modulate brain activity. Here's why it's revolutionary. It reaches deep limbic regions like the amygdala and hippocampus, which is critical for emotional processing. Theta band stimulation, which is 4 to 8 Hz, enhances emotional processing in prefrontal limbic circuits. And the theta band, which is 30 to 50 Hz, improves synaptic plasticity and cognitive function. And it needs no anesthesia, no seizures, and mild tingle in some cases. So for adolescents, this means personalized, brain-specific therapy with minimal risks. It's a game changer. So why we focus on high TACS? Traditional NIPS protocols takes 4 to 6 weeks for daily sessions, too slow for teens at acute suicide risk. Our resolution uses high-intensity TACS, which is 77.5 Hz, 15 milliampere, delivered twice daily alongside medication. We aim to answer 3 questions. First, is this protocol safe for adolescents? 2, is it more effective than medication alone? And 3, does twice daily dosing outperform once daily? So let's explore what we discovered. High-intensity parameters, we push TACS to 15 milliampere and 77.5 Hz, breaking conventional limits. And we modulated the hippocampus amygdala circuit, first to non-invasive methods. And we used twice daily sessions, compressed treatment into 2 weeks, not 4 to 6. while pioneering personalized neuromodulation for adolescent depression. We recruited adolescents aged 12 to 13 with first episode MDD, confirmed by DSM criteria. All were medication naive and no comorbidities like ADHD or bipolar disorder. Patients are randomized into 3 groups. Medication only, and once daily TCS plus medication, and also twice daily TCS plus medication. Assessment tracked symptoms at baseline, made treatment, and up to 8 weeks after baseline. Here how the intervention worked. Everyone received sertraline starting at 25 milligram and ramping up to 150 milligram. The TCS groups got 14-minute sessions at 15 milliampere and 77.5 hertz. One study group received 20 sessions over 4 weeks, then 4 weeks for medication alone. The study group received 20 sessions over just 2 weeks and followed by 6 weeks of medication. And we also strictly monitor for side effects. Let's walk through the results. By week 2, twice-daily TSS showed rapid symptom relief, deeper improvement than medication alone. By week 4, remission rates were 30% higher in TSS groups. And suicidal ideation, we can see that twice-daily TSS group reduced BSI scores significantly versus once daily and medication. And we can see that only 3 mild adverse events, tenderness and headaches, are resolved with adjustment, no seizure or mania. What does this mean for practice? We conclude 3 key points. First, safety always comes first. High TCS is well tolerated with an 85% complication rate, and twice-daily dosing cuts treatment time in half, which is critical for suicidal teens, and higher remission rates, faster anxiety reduction, and lasting effects. This is just not data, it's hope for family biting with MDD. Of course, our study is not perfect. Our had small sample sizes and short follow-up periods. We also lack of a sham control group, and environmental factors like family stress were not measured. But this limits opportunities. Next steps, we are going to have larger trials, biomarker integration, and longer tracking. And let's now turn to cognitive dimension of adolescent depression, often overlooked but critically important. MDD is not just low mood, it also includes attention bias, executive dysfunction, and cognitive inflexibility. One well-documented feature is attention bias toward negative emotion stimuli. This bias keeps patients locked in a loop of negative thought processing, making recovery very difficult. Unfortunately, current treatments rarely address these cognitive symptoms directly. That's why we incorporated this study, state virtual evoke potential SSVEP paradigm, a high-resolution EEG task that tracks how the brain processes emotional information. With SSVEP, we can assess how well patients attend to disengage from emotion cues, providing an objective marker of cognitive emotional modulation. So, how does SSVEP work in our study? Participants viewed emotional phases and GABA stimuli over a series of 4 blocks with 200 trials. Each trial featured flickering stimuli at either 12 Hz or 15 Hz, allowing us to track neural oscillations at specific frequency. It's not work. They were instructed to report changes in the orientation of GABA patches, while emotional stimuli like angry, sad, or happy faces were embedded in the background. This setup allowed us to track how emotional distraction impacted attention performance. With high TACs applied before and during this task, we could observe how the intervention modulated this bias. The goal was not just to reduce symptoms, but to actually relapse the cognitive circuitry associated with depression. Let's step back and reflect on what makes this study innovative. We used a high-intensity gamma band protocol, which is 77.5 Hz and 15 milliampere, which is rarely applied to adolescent populations. We demonstrated deep brain targeting, modulating that amygdala hippocampus circuit, which is often in access to TDCS or RTMS. Our study protocol provided accelerated clinical effects, helping patients achieve symptom relief in a shorter time frame. This treatment was non-invasive, well-tolerated, and had a high adherence rate. We are among the first to integrate high TACS with SSVEP, establishing a closed-loop neuroscience-informed protocol. In short, this is not just incremental improvement, it's a new framework for adolescent depressive care. In summary, our study shows that TACS is a promising treatment for adolescent MDD. It is safe, with no serious side effects. It is effective, especially in reducing symptoms and suicidal ideation. It acts rapidly with improvement of beginning with the first 2 weeks. It improves cognitive and emotional function, not just mood. And perhaps most importantly, it offers a new therapeutic option for a population underserved by traditional interventions. As we move forward, we are now scaling the trial to larger population, incorporating sham control arms and testing closed-loop protocols guided by EEG biomarkers. This future of adolescent depressive disorder treatment is here. It's electrical, precious, and personalized. Okay, here's my report. Thank you.